Good morning.
Good morning.
So let's see, where's Dr. Q? She's still here?
She just stepped out for me
Stepped
to come out of her car.
Okay, well, just as far as history goes, POTS actually goes back to the Civil War. So there's a description of Civil War soldiers who developed this syndrome of weakness and fainting. And so the description goes back further than the 40s. And recognizing it is actually interesting. Why do I have my phone here? Well, I just heard that this article was being published in a GI journal, but postural orthostatic tachycardia syndrome and GI tract, the primer for the gastroenterologist. And that just got published in August, late August, in one of our main GI journals. But you look in GI journals, and there's a Scandinavian journal that looked at mast cell in 2007, and the interactions and irritable bowel. Mast cell has gone back to descriptions in irritable bowel syndrome to 2004. But when you look at POTS, there's nothing in the GI literature. So as gastroenterologists, and many of you have gone to gastroenterologists and complained about a variety of GI problems, you get blank stares, or because you define normal treatments. So anybody with MCAS or POTS, you define normal therapy, and POTS again has been recognized. But again, when you go to your internist, they're not going to know about it because they don't read cardiology journals or neurological journals. So that's where the POTS literature has been. There's been a couple of review articles in the Mayo Clinic proceedings, but just in terms of recognition by physicians of the ailments that people have, it is difficult and set back. And so when I learned about these conditions, POTS and MCAS, and the title should be POTS and MCAS, GI disorders and bacterial overgrowth, small intestinal bacterial overgrowth, it's something that I was taught by patients. I became aware, and then I read and learned about the disorder, and then I started looking at all the challenging patients that I had over the courses of the year where I could not figure out the diagnosis, and then by understanding and being mindful of these conditions, then I was able to make a diagnosis. But 3 years ago when I talked to two of the smartest internists that I knew, and said, you know about postural orthostatic tachycardia syndrome, they said, you mean orthostatic tachycardia, orthostatic hypotension? I said, no. So, I mean, the recognition amongst internists is low. And so, it's a challenge to find your provider who knows the most, and luckily we do have some experts here, especially at St. Clair, and I think it's fantastic. And then there are some specialists that are getting on board, but it takes a lot, and it also takes a lot to find the fact that, okay, I've got POTS, but there are other things involved, and whether it's political with 3 bad people or nations, it happens in POTS. So the mast cell of the triangle here, tracing on the tilt table, or one of my patients who has Ehlers-Danlos, who's doing the yoga that Dr. Q recommended, but she's hyper-stretchy and hyperbendy, as they say, and these things relate. Many times, in the course of my readings and my own experience, I'd hoped that when I found patients with mast cell disease, if I treated the mast cell, we could really help the POTS. And that works sometimes, but not always. So these 3 diseases run around commonly. And then in terms of a mounting group of physicians who are interested, last February I had a 3-day mast cell seminar with Dr. Afrin teaching 30 people. And since then we've developed a listserv, so we have a email system where people present cases and discuss new findings, and a common theme that people have been finding is the pentad. So not only is there a role for understanding mast cell activation syndrome, POTS, and Ehlers-Danlos syndrome, but there's many of these patients will have motility disorders or autoimmune disorders. And autoimmune antibodies, Sjogren's syndrome, lupus, and that may play a role accelerating more than just the three common syndromes. As a gastroenterologist, I highlight the things that people see me for, and when things don't go well, things don't respond to normal FDA-guided therapy or society-guided approaches towards working on patients and treating them for gastroesophageal reflux disease, GERD, you gotta start thinking about POTS. So the esophagus is commonly involved in POTS. Difficulty swallowing or dysphagia is common. And abnormal gastric emptying is common. Half the people have very slow emptying, and half have very fast emptying. So actually it's, through gastric emptying studies, 45% of POTS patients will have abnormalities, half fast, half slow. It's easy to understand the slow ones because of the sympathetic overdrive. You don't have the vagal response, which is the normal digestion and peristalsis that occurs. And it's a little harder to understand why people have fast emptying of the stomach, but when you eat a meal and then you rapidly develop nausea, that may be an explanation why that is a problem. So it's not necessarily when you have nausea that it's just sitting there in your stomach. It could be simply too rapid emptying. The sphincter problems and motility problems involve the colon. So when there's sympathetic overdrive, you lose the peristalsis. You can lose the peristalsis in the small intestine. And with that, you see dilation of the small bowel. And I'm going to say that's a preface to talking about small intestinal bacterial overgrowth later on. The sphincter problems are a big problem in patients with POTS who have inability to relax the anal sphincter. So many patients have this problem of non-relaxing tuberoctalis. Why somebody's sphincter should tighten up when they're trying to poop, and as opposed to relax, has always been a mystery to me. But understanding that dysautonomia is common, I think that is a big factor. And then Dr. Quattromani talked about many of the other aspects. Again, usually sympathetic overdrive. Migraines and headaches are extremely common, and that could be part of the mast cell picture. There's mast cell release of mediators that could play a role. Brain fog and anxiety and depression we're going to talk about with mast cell in a little bit. If you look at the 50% most common symptoms, they're posted here, but many present just with GI symptoms and fatigue. As far as sticking to what I do as a gastroenterologist, I'll just highlight the median arcuate ligament syndrome. So this is something that's important to think about. The incidence is not yet worked out, but it is definitely a cause of POTS. And when you look at this condition, basically it's the diaphragms have fibers and the blood vessels go near them, and the celiac artery passes by one of the fibers and connective tissue of the diaphragm, and it can develop a kink, so it's pulled up. And so with that, there can be neuropathy there, autonomic dysfunction, and there's selected surgeons around the country that understand in the POTS patient this can play a role, and that denervating the ligament, nerves around the artery are just as important as releasing it to get rid of the kink. So I have a few patients who have undergone that surgery, one excellent response, one poor response, but it's important to think about it. So Dr. Q, of course, pointed out mast cell activation is important. I'm not an expert in all aspects to POTS, but I think that sympathetic dysfunction is very important. She highlighted the fact that the mast cells do situate themselves along the nerve, and studies out of Vanderbilt have shown that the hyperadrenergic state is more apt to occur with mast cell activation, and it could be that the release of the chemicals from the mast cells in the autonomic nerve sheath bundle plays a role in POTS. And in these patients, I think we hope that treating the mast cell disorder can help in addition to the standard mast cell phenomenon. Ehlers-Danlos seems to play a role, and especially for pain and GI symptoms in POTS. So here's a study at Vanderbilt and many other institutions in a multi-center study. They looked at nearly 3,400 patients. Ehlers-Danlos was common, 30% of patients. They often had it during their whole lifetime. When you looked at who had more GI symptoms, the ones in red, the ones with Ehlers-Danlos, had a higher incidence of GI symptoms, although pretty common, in many of the POTS patients. Small study looked at these dilated loops or air fluid levels in the small intestine in POTS, and so 57% had these abnormal changes, suggesting again that we're not having normal peristalsis. And if you've got this basically slow-moving intestine, it increases your risk of bacteria building up in this area. Mast cell activation syndrome, the majority likely develop it at birth or early on in life. I have a family of 3 kids with mast cell and POTS whose mom is affected in the same manner and probably passed on the mast cell stem cell that had mutations. Others develop mutations early on in life, and it leads to multiple system involvement. These patients have inflammation or allergic phenomenon. They see many physicians, and it's a big complex of symptoms that physicians will see the patient and then glaze eyes because how is it possible for people to have 45 different symptoms that make them disabled? But unfortunately, this is what it is, and hopefully more education will help. And when I saw that the primer for gastroenterologists and POTS was coming out, I thought this is a great opportunity to write an article. So we're on our second draft of the manuscript. Dr. Affer and Moldering's a very innovative gastroenterologist in Utah who does mast cell and POTS work, doing basically an article for the same journal, and hopefully they'll accept it. But basically a primer for gastroenterologists so that it gets into the GI literature and people can understand how to address it and treat it. Part of the problem with mast cell disease is that this little cell can secrete over 200 different chemicals, which can cause pain, itching, rash, flushing, inflammation. They can cause clotting disorder or bleeding disorders, depending on what this mast cell wants to put out. And we're only able to actually look at and measure 6 different types of chemicals in the lab. There are in highly sophisticated labs, of course, tests that have been done to say, indeed, there are more than 200 mediators that are reported. Now, so symptoms will help make the diagnosis. So if you look at the classic symptomatology, let's say hives and flushing or itching, okay, that's a positive. Skin, GI symptoms of reflux or irritable bowel symptomatology, again, another symptom involved. And then you can add to that other of the symptoms, whether it be constitutional fatigue and neurological symptoms. The most common symptom of MCAS is muscle pain and chronic fatigue, which of course sounds like fibromyalgia, which is what it usually is given as a wastebasket diagnosis, and many people see their rheumatologist for this condition, but they don't take it a step further to say, okay, could this be a system-wide disease such as mast cell activation syndrome? So measuring and counting mast cells in biopsies, in particular the small intestine duodenum or the end of the small intestine, is helpful. The problem is maybe too sensitive. There are so many patients that I see who I consider the diagnosis, and literally 97% of the time they do make the diagnosis criteria of having more than 20 mast cells. So I feel that it's important to biopsy and help make the diagnosis, because the major criteria are here: positive symptoms, positive biopsy, but the secondary or minor criteria I think are very important. We want to get the blood or urine test of a chemical or mediator over here. That's important. And then we want to see if they respond to mast cell-directed therapy, such as antihistamines, cromolyn, aspirin, as was mentioned, although we have a caveat there that so many patients are allergic to different chemicals or and such severe allergies that you have to be careful of aspirin and non-steroidals. So it's important how these tests are run to make sure that the plasma is run cold or in a chilled centrifuge, that it's frozen right away, and that the urine tests are collected for 24 hours in a cold situation where the urine is then put right back into the refrigerator in the bottle or kept on an ice chest with ice and transported to the lab, because these chemicals are very sensitive and break down. And then just recently I read an article that one neurologist in Canada, Dr. Raj, who's done a lot of work, does heparin histamine testing in the urine only after an attack of flushing and only for the next 4 hours, because if he stretches it out over the classic 24 hours, they're normal. So it's a challenge. Currently, in 170 patients, I have 60% yield of finding a positive test. So Ehlers-Danlos and mast cell activation, you can actually do biopsies in skin around joints, but not at the joint where the pain is, and find increased number of mast cells. It's increased frequency, and there's a role that we're going to get into, which goes into discussion of bacterial overgrowth in a moment. So small intestinal bacterial overgrowth, SIBO, is a common phenomenon. If you look at people with irritable bowel syndrome, which is about 15% of the population, 60% have bacterial overgrowth. And of those people, 60% have it due to an autoimmune disorder, namely post-infectious irritable bowel syndrome. I'll spend a little time on that later. But there are many causes for bacterial overgrowth, and there are ways that our body prevents that. So if we have acid in our stomach, we're not taking high-dose proton pump inhibitors, we destroy the oral bacteria that goes down into the stomach, and when you measure the bacteria in the stomach, it's very low and it's all oral. If, however, you're on an acid blocker and you can get bacterial overgrowth from oral bacteria, not as toxic as if they're colonic bacteria. So people who have poor hand washing or have the misfortune of getting, let's say, bad contact with going into a public restroom, for instance, and then touching their mouth and acquiring somebody else's colon bacteria, as bad as it sounds, this is GI, then you can swallow colonic bacteria, and colonic bacteria are very toxic, and if you either can't absorb the nutrients well and you're feeding it, such as in people who have chronic pancreatitis or celiac disease or low acid levels, then that bacteria can increase in numbers and adhere to the wall. Or it can go further down, and because of motility disorders or poor immunity, attach to the wall and grow and live there for a long time. And we'll talk about the consequences of that. Patients with Crohn's disease will lose part of their colon, usually over here, and the ileocecal valve, ICV, is an important factor, physical factor, to prevent bacteria from going back up into the small intestine. So we normally have very few bacteria in the small intestine because we have good motility and immunity, and if we lose that, then it can become like a swamp. And so, or a sewer, if you will. So those people with Ehlers-Danlos syndrome can get into trouble with bacterial overgrowth because they have loose mesentery, and then they have these droopy loops, and they can't move things out well, and so they can get bacterial overgrowth. How do you diagnose it? Well, it can be a clinical diagnosis, but to be more exact, we do lactulose breath test. Some labs do a glucose breath test, but glucose is absorbed within the first 3 feet of the small intestine, so it doesn't sample the bacteria lower down. So what do we mean? So when we give sugars and we have patients breathe into a tube and then measure how much hydrogen or methane they make, it should be low. Basically, they should be having low levels because there aren't bacteria to ferment those sugars. So what happens is when you take a sugar and you breathe into a tube and you expel your air, you're analyzing what's happening from the gut to the lungs into the bag. So namely, you take the sugar, if there are excess bacteria there, the bacteria are fermented, then the gases get absorbed through the lining of the intestine, go into the bloodstream, go to the lungs, and then come out in the breath. And that's the basis of how you measure breath testing. If you have many bacteria higher up in the small intestine, then you're going to get a peak earlier on. So in the upper part of the small intestine, excess bacteria will eat the sugars, ferment, and then you'll see what's going on. We can actually only measure 3 types of gases, and the third gas, hydrogen sulfide, is the one that causes a rotten egg smell, and that's only now in a new test model that is yet to come out commercially. So what is small intestine bacterial overgrowth all about? Well, it's a change in what's normal. And what's normal is that here's a happy gut, is that you've got good bacteria on the surface. So we all do have some degree of healthy bacteria on the surface, primarily in the colon, but some in the small intestine as well. And those help defend and feed the lining of the cells, healthy products to grow normally. And so there's a mucus layer, and then there are goblet cells which produce mucus, and then there are endochromatin cells which help produce healthy chemicals, nourishing the cells. And then the nerves actually integrate with the lining of the cells, and under normal circumstances, these nerves help sense what's going on, and they help contribute towards motility to some degree, but there's feedback along the way, and that's helps the intestine know when it's distended and know when to contract. And then finally, these cells are tied together with tight junctions, which are supported by chemicals, zonulin included. When there's bacterial overgrowth, small intestinal bacterial overgrowth, we have the bad bacteria taking over the good. There's destruction of the mucus layer. So chemicals can get through a bad mucus layer. There's damage to the tight junctions, and that leaky gut, so to speak, or in medical terms, increased intestinal permeability occurs. And when that occurs, then we get a response by the immune system. And so the chemicals come down, excite the dendritic cells, which draw in T cells and mast cells. And those, what happens there is the mast cells will then produce inflammatory chemicals, histamine, which is in the gut, a painful chemical, and the T cells produce tumor necrosis factor and interleukin-6, which are chemicals which will feed back and actually damage the lining of the intestine, creating a vicious cycle. So this is basically the chemical or the local view of what's happening in SIBO. But what happens to you if you have small intestinal bacterial overgrowth? Well, what happens is the bad bacteria build up in areas where there's not supposed to be bacteria in the small intestine. The sugars, the carbohydrates, the gluten that you eat are chewed up and fermented by the bacteria before they get absorbed, and by doing so, you'll get more gas, trapped gas, because gas in the small intestine stays trapped until it can get absorbed into the lining. Only 10% comes out as flatus. The rest really actually comes out in your breath because it's trapped. So people get bloated and uncomfortable. Some of the byproducts are acidic, and that causes increased peristalsis and diarrhea. And the other things that happen is this inflammation. So this inflammatory pathway is going on. These chemicals are absorbed and go into the blood vessels and can contribute towards inflammatory conditions, muscle pain, depression because of a reaction with the brain chemicals, change in your pituitary adrenal axis. Chronic fatigue is an aspect of this condition, and it can create, quote, what a typical irritable bowel syndrome patient has, but many other syndromes as well. The mast cells generally stay here, and if there's a mutation that it can occur, it would in certain individuals who are prone, and then the mast cells will stay for a long time, and they will produce more chemicals and histamine, which then activates the nerves, which causes chronic pain in the gut. And so even if you have distension to a lesser degree than a normal person, you'll experience pain there because the nerves are basically fried a little bit from all the chemicals. Mast cell activation syndrome is a common disorder. So it's been mathematical models have shown 17%. There was a study in Germany that actually looked at a group of patients, and 17% was the incidence of mast cell. And again, because of all the symptoms that it can produce, it can basically account for a number of conditions and syndromes that have been diagnosed by other individual specialists as fibromyalgia syndrome, chronic fatigue syndrome, and chronic pelvic pain syndrome, such as interstitial cystitis and chronic prostatitis. As far as being a gastroenterologist, these are the symptoms that we normally see, and they're highlighted